Hello, welcome to your online lecture for the course Pathophysiology 1. In today's lecture, we're covering endocrine disorders. On this slide, you can see an image showing you the various different glands or endocrine glands that are found throughout our body that have major roles in producing and secreting hormones that contribute to so many of our body functions. And in today's lecture, we're going to talk about some of these glands and what happens when there is a disorder of them. So we'll be looking at the pituitary, the thyroid, the parathyroid gland, as well as adrenal medulla. Now, the pancreatic disorders will be covered during our diabetes mellitus in-class lecture. We'll start with pituitary gland disorders. Just a reminder of the pituitary gland and how it has two lobes, the anterior lobe and the posterior lobe of the pituitary, and that they're connected to the hypothalamus by a stalk called the infundibulum. Most alterations and disorders related to pituitary gland dysfunction are related to the anterior pituitary gland, primarily because of the many different hormones and different functions that this pituitary gland has. The pituitary gland relates to so many different hormonal systems throughout our body, and so when it has a disease or some sort of disorder, it can impact the different hormonal development systems of other organs in the body. So for instance, if there's a problem with the pituitary, it can impact the way that the thyroid gland can function, the testes, the ovaries, etc. And so you can see in this image all of these target glands of the pituitary gland. This slide talks about the inappropriate secretion of antidiuretic hormone, or ADH, and it can either be secreted in higher than normal amounts or lower than normal amounts. Before we get into that, though, a reminder of the physiology of antidiuretic hormone. As you can see, it's produced or released by the pituitary gland. And it's going to be released whenever plasma osmolarity is too high. And so if there's too much sodium, therefore not enough water, then ADH will be released by the pituitary gland, which will work to promote the reabsorption of water at the level of the kidney in order to return the body to homeostasis. High ADH secretion is much more rare, so it's not as common as low ADH secretion. But when high ADH secretion is present, it is part of a condition called syndrome of inappropriate ADH secretion. The syndrome of inappropriate secretion of antidiuretic hormone develops when there's too much antidiuretic hormone released by the pituitary gland under certain inappropriate conditions. And what this can do is cause the body to retain fluid and really lowers the blood sodium level by process of dilution. Remember what the term antidiuretic actually means so that you can understand what it's involved in. Diuresis is increased or excessive production of urine. And so antidiuretic hormone is just the opposite. It's going to promote the reabsorption of water within your body rather than the production of urine. And so there's normal things that are part of certain every day or every week in terms of events such as alcohol consumption and caffeine consumption, which can promote urination, having what's referred to as a diuresis effect. Now, in terms of low ADH secretion, the more common of the two, this can be seen in diabetes insipidus. So in this case, secretion of ADH is reduced. Now, if the pituitary gland is damaged by infection or tumor, it can lead to this condition of diabetes insipidus. In addition, those that have hypothalamic pituitary tumors can end up with low ADH secretion, and meningitis can cause this as well. The inflammation that comes on with meningitis can impact the pituitary gland, reducing its overall hormonal secretion. And some of the effects that are seen are going to be polyuria, so this is excessive urination, plasma hyperosmolarity, as well as polydipsia. Polydipsia is excessive thirst. And the intention of this excessive thirst that the body triggers is because of the hyperosmolarity. Hypopituitarism is the absence or deficiency of one or more of the anterior pituitary hormones, or it could be the complete failure of all anterior pituitary hormone functions. There could be an inadequate supply from the releasing hormones, for example. So here are all your releasing hormones from the hypothalamus. And this would then be a result of decreased hypothalamus function. So you can see how a problem with the hypothalamus can then lead to a problem with the anterior pituitary. So the anterior pituitary, if it's not getting the proper stimulation from the releasing hormones, then it won't release its hormones. Listed on the right are some of the more common causes of hypopituitarism. But I want you to look here. You can see decrease in all of these different hormones, with the exception of prolactin. And this is an interesting one, because what we'll see in this case is that there's a decrease in the inhibitor of prolactin, causing an increase then in prolactin or milk formation. But back to the causes here on the right, there are many different causes. We have central nervous system tumors that can lead to problems with the pituitary function, hypophysectomy, which is actual removal of the pituitary, head trauma, infections of the central nervous system, and Sheehan syndrome. A little bit more on Sheehan syndrome. This occurs when after a woman delivers a baby, so postpartum, the pituitary gland can undergo necrosis. And this can happen if there's a lot of blood loss, for example, after birth. If blood volume goes down, it can lead to Sheehan syndrome. And this condition could potentially affect all of the hormones that are released by and produced by the anterior pituitary gland. And before we go into the next slide, let's have just a little bit of a closer look at what would happen in the event that certain hormones are reduced in terms of their production and secretion. Follicle-stimulating hormone and luteinizing hormone in females can lead to amenorrhea, so absence of a period, or menstruation. Can lead to reduction in thyroid-stimulating hormone, can lead to hypothyroidism because it's not getting the stimulation that it needs. Reduction in adrenocorticotropic hormone can lead to Addison's disease, and we'll talk about that later. Increase in prolactin can lead to what's called galactorrhea. And galactorrhea is defined as excessive or inappropriate production of milk. And a reduction in growth hormone can lead to a reduction in overall growth, and we'll look at that a little bit closer today as well. This slide discusses hyperpituitarism, so this is opposite to what we spoke about on the previous slide. And this involves the increase in production or hypersecretion of hormones. And it's usually because of a pituitary adenoma, which is a benign, slow-growing tumor that arises from the cells of the anterior pituitary. And the cause of this, for the most part, is not known, and most actually occur quite sporadically. It's more common in young adults. Now, because there are many different cells within the anterior pituitary gland that produce different hormones, depending on which cell type is affected by a pituitary adenoma will determine which hormone production will be affected as well. But what's interesting to note is that if you have a benign tumor such as a pituitary adenoma that affects one particular cell type, it can cause hypersecretion of that particular cell type. But if it's putting pressure on the cells around it, then it can cause hyposecretion of the hormones of that cell type. So in other words, the tumor itself can cause hyperpituitarism of the tissue that it is affecting, so the cells that it is affecting, and it could cause hypopituitarism of the neighboring cells around it that are being compressed. And so, for example, if we have increased growth hormone, it can lead to a condition called acromegaly, which we'll talk about later. If there's increased thyroid stimulating hormone, it can lead to hyperthyroidism, which we'll also speak about. And then increase in prolactin can lead to galactorrhea, which is a condition then that can result from both hypo and hyperpituitarism based on what we spoke about on the previous slide. Here's the comment that I made about compression of pituitary cells in the surrounding area that could lead to hyposecretion of those cells and their corresponding hormones. Visual field alterations can also be seen. So if there's local expansion of a pituitary adenoma, it can actually impinge on the optic chiasm, and it can cause various visual disturbances depending on the particular area of the optic nerve that is compressed. And then finally, increased intracranial pressure. We know that anything that's growing inside the skull that shouldn't be there, because there's not a whole lot of room for it, the increased size of this tumor will lead to increased intracranial pressure, which could cause all of the problems that we know that can come from this condition of increased intracranial hypertension. A little bit more on pituitary adenomas, just to show you the normal anatomy of the pituitary gland. We can see that this small gland that hangs off of the, or relatively small gland that hangs off of the hypothalamus, we can also see that it sits in a nice little, almost a little cubby, and that's called the sella turcica. You can see it a little bit closer here, and that's a part of the sphenoid bone. And so it sits nicely in here, and so if there is a tumor of this gland, it could end up impacting the bone around it, but also put pressure on the optic nerve, which is not far. So here we have the optic chiasm, so you can see that close proximity as to why it would damage it. And the optic chiasm is just where the two optic nerves cross. And just looking at some images of what a pituitary adenoma would look like and the increase in size within the brain. This slide discusses acromegaly. We introduced this when we spoke about growth hormone. When growth hormone is produced, it travels to the liver to stimulate the production of insulin growth factors that contribute to the normal growth of muscles and bones. But in the case of excessive production of growth hormone, then it can lead to a condition called acromegaly. And this condition, it would result from, yes, too much growth hormone, but it's important to know that this is happening after the growth plates have closed. And you can see a lot of distortion in terms of how the individual looks as time goes on when they have this tumor. Whereas you may have heard of gigantism. This is similar, but the main difference is the period at which they occur. So gigantism then occurs during childhood before the growth plates have closed, whereas acromegaly appears in adulthood. And it's almost always caused by a benign pituitary tumor. And so here is your pituitary gland, and we have the liver, insulin growth factor, which is going to contribute to muscle growth, bone growth, among other growths. Thyroid disorders is next. The main function of the thyroid gland is to produce thyroid hormones, and this is controlled really by the central nervous system, so the pituitary gland and the hypothalamus are in control of that. And they are, we know, a part of glands that are found within our brain. And thyroid disorders can either be primary or secondary, which you can see listed here. And primary would be that it begins within the gland itself, or so it's maybe disease of the thyroid gland itself. But secondary are those that are related to central nervous system problems. So for example, there could be a pituitary adenoma, or maybe there's a problem with the hypothalamus, and then the thyroid itself secondarily will be affected by that. We can either have hyperthyroidism or hypothyroidism, and we'll look at the comparison of each shortly, but you can see on this slide here some of the main differences between the two. Lower, you could almost summarize it to state that there's a lower metabolic rate, whereas with higher, there's a higher metabolic rate in comparison to normal. And so you can see things such as constipation with hypothyroid and diarrhea and subsequent weight loss as well. With hyperthyroidism, those that have a hypergland are more likely to have warm hands, for example, warm skin versus cold with hypo. You can see faster heart rate, tachycardia versus slower heart rate. And this sort of does fit in with overall increased metabolic function when you think about it versus reduced metabolic function. And we'll talk about a couple of these other conditions in an upcoming slide. The final key term to mention before we carry on is the term goiter. A goiter is defined, as stated on the slide, as total or partial enlargement of the thyroid gland, but what's important to note is that this can occur with either hypothyroidism or hyperthyroidism. Let's begin with hyperthyroidism. In this case, your thyroid hormones, so T3 and T4, are elevated. And there are two main causes. We have Graves' disease and we have nodular goiter. These are really our major causes. Graves' disease is the most common cause. It causes about 80% of cases of hyperthyroidism. It most commonly affects women. And it is considered a type 2 hypersensitivity, where there's antibodies against thyroid stimulating hormone receptors, and we can see that here, thyroid stimulating hormone receptors. There's antibodies against it. And this can lead to inflammation and destruction of the cells. Ultimately, what it results in then is going to be proliferation of the cells, which results in the thyroid being enlarged, which contributes to the term goiter. Graves' disease is considered an autoimmune disease, with the body attacking itself, as I already explained. But to rephrase it a little bit, the initial changes that are seen to a gland is that there's the infiltration of lymphocytes found, and the stimulation of the thyroid by autoantibodies that are directed against the thyroid stimulating hormone receptors. And these autoantibodies have a particular name, and the name of these is called thyroid stimulating immunoglobulins. Okay, so these are the antibodies against the receptors for thyroid stimulating hormone. And what they end up doing is overriding the normal negative feedback that would otherwise keep everything at its proper level or at homeostasis. And so it's the stimulation of the thyroid stimulating hormone receptors by the thyroid stimulating immunoglobulins that leads to this hyperplasia of the gland, or the presence of that goiter. And then what we'll see from there is increased synthesis of thyroid hormones. So we could have both T3 and T4 elevated, but I should note that in particular what would be elevated would be T3. And the increased levels of thyroid hormone will affect really every physiological system in the body, leading to the classic signs and symptoms of the disease that we saw on the image on the previous slide. There are two main clinical manifestations of Graves' disease that are important to note. One of them, and I've written both on the screen here, ophthalmopathy and dermopathy. Ophthalmopathy, sometimes referred to as thyroid eye disease, is commonly seen, or I shouldn't say commonly seen, but can be seen in Graves' disease, and it's an autoimmune inflammatory disorder of the orbit as well as the periorbital tissues, and so it can be characterized by upper eye issues, so retraction of the upper part of the eye, the eyelid can lag, there can be swelling as well as redness that is present. Dermopathy, this is a skin condition, and it can develop as a result of changes to the blood vessels that supply the skin, and sometimes it can appear as these shiny, round, or oval lesions over the front lower parts of the lower leg, so over the shin. Sometimes it's referred to as shin spots that can be seen in these individuals. But another feature I'd like to mention is called exophthalmos, and I'll go back to the previous slide to show you that term in case you're wondering about the spelling. And it's right here, exophthalmos. This is a sign of hyperthyroidism, And what it involves is the protrusion of the eyes outward. And it's oftentimes a very obvious sign in those that have it for those that are observing them. And the reason that this happens, the exophthalmos, is because there's edema present. There is also increased secretion of hyaluronic acid in the area, adipogenesis within the area, and inflammation as well. And all of this builds up and causes the outward protrusion of the eyeball. Now we'll move on to talking about nodular goiter. With nodular goiter, so normally the thyroid gland can and will enlarge in response to certain situations. So if there's a situation where increased thyroid hormone is needed, then there'll be increased stimulation by thyroid stimulating hormone. And in certain cases where this can happen normally would be, for example, during puberty, during pregnancy, and there's certain disorders that can occur where this happens. But this is really a compensatory process, and the gland should, in theory, return back to its normal state after the condition that required the increased thyroid hormone resolves. So, for example, you have a pregnant patient that has enlargement of her thyroid gland because increased thyroid hormone is required, but then once she's not pregnant anymore, then the gland should return to its normal size. So it adapts under certain circumstances. But sometimes some of the follicles that had enlarged, they don't return to their normal state and they can form nodules. And these nodules can cause an increase in thyroid function in these particular area. Sometimes these nodules can actually be palpated as well. Now, unlike Graves' disease, nodular goiter is not an autoimmune condition. And there are actually quite a few different types of nodular goiters, but we're not going to be getting into the details. But you can see that hyperplasia does exist. In this case, a goiter is formed. And this is when some follicular cells don't return to their normal state. And the final point I'd like to make here is about thyroid pills. If you have an individual who's on a thyroid medication and they overdose or they're taking too much, then you could probably see why that could create hyperthyroidism. Hypothyroidism results from deficient production in thyroid hormone by the thyroid gland, and it is the most common disorder of thyroid function. It is also more common in women and more common in the elderly as well. It can be primary or secondary, but primary accounts for 99% of all cases. Hypothyroidism can be subclinical, meaning somebody can have issues with their thyroid not producing enough thyroid hormone and not necessarily have enough signs and symptoms to be aware that there's a problem. So they have a lower metabolic rate, but they're not aware of it. The examples of primary hypothyroidism are Hashimoto's disease, thyroidectomy, and iodine deficiency. With Hashimoto's disease, lymphocytes attack the thyroid in such a way that it causes hypothyroidism. And so we can say that it is an autoimmune disease then. Thyroidectomy. Ectomy is removal of the thyroid would naturally put somebody into a state of hypothyroidism. And iodine deficiency as well. So how does the thyroid gland relate to iodine intake? Well, the function of the thyroid gland is to take iodine, found in many of the foods that we eat, and convert it into the thyroid hormones thyroxine, which is T4, and triiodothyronine, which is T3. Thyroid cells are the only cells in the body which can absorb iodine. And what they end up doing is, that is the cells in the thyroid, is they combine iodine and the amino acid tyrosine to form T3 and T4, which are our thyroid hormones. We also have secondary hypothyroidism, and sometimes this is called central hypothyroidism, and it's related to either pituitary failure or hypothalamic failure. And you can see, looking at this image, the three mechanisms the main ones that can contribute to hypothyroidism. So we have primary thyroid malfunction, which we spoke about at first, and then there is secondary hypothyroidism, which involves pituitary and hypothalamic malfunction. And depending on what the actual cause is, will determine what you end up with. So you can see that thyroid hormone, thyroid stimulating hormone, and thyroid releasing hormone are all going to be affected in different ways depending on what the actual mechanism is that's contributing to hypothyroidism. Now let's speak about thyroid cancer. Thyroid cancer is the most common endocrine malignancy, but it constitutes only about 4% of neoplasms. The amount of thyroid cancer in Canada is actually increasing, and there's not an exact understanding as to why that is. Thyroid carcinoma is the most common and most often seen of thyroid cancer in terms of type. And most of the tumors of the thyroid gland are well differentiated with this cancer. And when it comes to well differentiation, it tells us that it's not really aggressive. And so it's a type of cancer that oftentimes people do recover from, or I should say survive. Ionizing radiation. There is a link between exposure to ionizing radiation and thyroid cancer, which you probably heard of. And it's related to radioactive iodine. And so when someone's exposed to radioactive iodine, it goes directly to the thyroid and it's carcinogenic, so it can cause cancer. But there are other cancers too, and this is an area that's being researched right now. Individuals with thyroid cancer usually have normal thyroid hormone levels. So if they present to their doctor and they've got a mass in their throat region that is affecting the thyroid, when it's cancer, it's oftentimes not affecting the actual hormone levels. So hormone tests won't show that there's any alterations in their hormone function when it comes to T3 and T4. And usually what will happen is these individuals will discover a small nodule, maybe themselves, or their doctor during just a regular checkup will discover a small nodule. Sometimes it's not detected until it's spread. It could spread, of course, to other organs in the body, but it can also spread to lymph nodes in the area. And sometimes the lymph nodes are evident before the cancer of the thyroid is. Sometimes individuals, depending on the size of the tumor, will have changes in their voice and they'll have difficulty with swallowing, maybe difficulty with breathing. And the reason for this is because the tumor growth can impinge on the trachea, so the breathing tube, as well as the esophagus, which is the food tube. Now, in those that have an ultrasound of their thyroid, the results may be characteristic or may be suggestive of malignancy, but these tests are neither sensitive or specific to that. But overall, the mortality for thyroid cancer is considered low. Now on to parathyroid disorders. And we're going to be specifically talking about disorders relating to the parathyroid gland. And we'll have a look on the next slide to show you where the parathyroid glands are located. So if this is the thyroid gland, which we just spoke about quite a bit, you can see that there are 4 glands, 2 on either side, and these are the parathyroid glands. If somebody has a thyroid disease, it will often spare the parathyroid glands because they're separate glands. However, let's say, for example, somebody has to have their thyroid removed, so thyroidectomy or some sort of, maybe part of their thyroid removed. Sometimes what can happen is the parathyroid glands are nicked, or injured, oftentimes unintentionally, which can lead to parathyroid disorder, long-term or just temporarily. And so the image below shows the normal physiology here of what the parathyroid gland does. And we can summarize and say that parathyroid hormone will elevate calcium levels in the blood in response to a reduction in serum calcium. You can see that increase in parathyroid hormone secretion from the parathyroid glands. And the purpose is going to be then to bring our body back to homeostasis by increasing serum calcium. And so how this is done is, for example, the bone is going to be broken down to release calcium, so calcium can enter the blood. The kidneys are going to be stimulated as well so that there's less elimination and more resorption. And the intestinal tract is going to be stimulated in order to increase absorption of calcium in the small intestines, but this is dependent on vitamin D. Our kidneys are required to, or specific receptors on our kidney are required to be functioning in order to activate vitamin D. So when vitamin D is in our body, in order for it to be activated, the kidneys are involved. And activated vitamin D is important because it allows for the absorption, it assists with the absorption of calcium from our diet into our body in order to increase serum calcium levels. So all in all, with the bone, the intestinal tract, and the kidney, we are working to increase serum calcium levels to bring us back to homeostasis, thanks to parathyroid hormone from the parathyroid gland. This slide contrasts the different types of parathyroidism. So we have hyper and hypoparathyroidism. Hyperparathyroidism is characterized by a greater than normal secretion of parathyroid hormone, and so then it's also coincides with hypercalcemia, which makes sense based on what we just spoke about on the previous slide. So anemia has to do with the blood, and here we have calcemia or calcium and lots of. And so then the opposite would be true with hypoparathyroidism, where there's a reduction in parathyroid hormone secretion, which would lead to lower calcium in the blood, or hypocalcemia. The most common primary cause of hyperparathyroidism is by parathyroid adenomas, followed by hyperplasia. And then a small percentage would be relating to parathyroid carcinoma, so cancer of the parathyroid gland. But it can also be secondary. So we just spoke about primary. With secondary, if someone has renal failure, or if there's low intake of calcium, or if there's issues with absorption of calcium, for example, we spoke about vitamin D deficiency as an example. If vitamin D is not present, then the body isn't going to absorb as much calcium. If the kidneys are failing, maybe we aren't resorbing, we could hold on to too much calcium, or possibly the receptors are not working properly in order to activate vitamin D, then there's stimulation of the parathyroid gland to produce even more parathyroid hormone. And what this can result in then is pathological fractures, because we're pulling too much calcium from our bones because we're not getting enough calcium elsewhere, that can lead to weaker bones and fractures, but these are specifically called pathological fractures. And because of the accumulation too of calcium within the blood from hypercalcemia, it can lead to the formation of kidney stones. The most common cause of hypoparathyroidism is trauma during thyroidectomy. So I mentioned this already, where if the thyroid is removed, or even part of it is removed, then there can be accidental injury to the parathyroid glands because of their close proximity. And low parathyroid hormone can lead to increased excitation of nerves and muscles. It can lead to spasming of muscles. And we spoke about this when we talked about different imbalances in the body in one of our previous lectures. And then we have Chvostek's sign, and this is a clinical sign of existing nerve hyperexcitability, or tetany, that's seen in cases of hypocalcemia. And remember that this sign refers to the abnormal reaction to stimulation of the facial nerve. And once again, we spoke about this earlier in the term. Now we'll talk about adrenal disorders. Remember that the adrenal glands are found on top of the kidney. So ad being on top of, renal referring to the kidney. And I want to remind you just a little bit about the anatomy and physiology of the adrenal gland. So around the outside, we have the cortex, and then the inside, we have the medulla, and they both secrete such different hormones that it's almost like they're two different glands in themselves. The cortex, if you recall, produces an important hormone called aldosterone. Not only aldosterone, but that's the example that I'm giving. And aldosterone is involved in sodium balance in plasma. So aldosterone oftentimes works alongside antidiuretic hormone. And then the other hormone to mention is cortisol. Cortisol also produced by the cortex of the adrenal gland. And cortisol we have heard of before as being really referred to as the stress hormone. And so that will come up again on the next slide. And then the adrenal medulla, so the inner layer here. So all through here. The adrenal medulla is connected with our sympathetic nervous system. And so it's involved in our fight and flight response and in the production of catecholamines. So if we look at the adrenal medulla here, we have different catecholamines that exist, with norepinephrine and epinephrine being the big ones that are usually referred to when talking about hormones of the adrenal medulla. Okay, so the inside here is the medulla, and then the outside here is the cortex. Adrenal disorders can be classified as those that affect the cortex and those that affect the medulla. Adrenal cortex disorders oftentimes are related to cortisol, and they can either be hyper or hypo, so hypercortisolism or hypocortisolism. Hyper is also known as Cushing's and hypo as Addison. Causes of hypercortisolism include glucocorticoid drugs. You could have somebody who is taking prescription glucocorticoids to treat inflammation that's caused by a variety of different illnesses, for example. It can be caused by pituitary adenoma, where the pituitary gland, because of the adenoma, is secreting too much ACTH, or adrenocorticotropic hormone. And what hypercortisolism can lead to is hyperglycemia, and it's almost like the body is constantly in a stress response. And so this can be concerning for someone who's a diabetic, but Cushing's disease itself can also lead to the development of diabetes because of hyperglycemia in some cases. Weight gain is the most common feature, and it's oftentimes seen with accumulation of adipose tissue in particular areas. So the face, the trunk, and the cervical or the neck regions. And this is a very characteristic pattern of fat deposition with hypercortisolism. Hypo, referred to as Addison's disease, this is really, for the most part, a primary adrenal insufficiency. And it's relatively rare. But the most common cause of primary hypercortisolism is autoimmunity. So autoimmune destruction. There are also other causes, including inadequate stimulation of the adrenal cortex by adrenocorticotropic hormone. Certain infections of the adrenal gland can lead to hypocortisolism. For example, if somebody has tuberculosis, HIV, or even meningitis, once it gets into the blood and causes bacteremia, it can travel to the kidney and infect the kidney, impairing its overall function. Withdrawal of exogenous glucocorticoids. So when we say withdrawal, it's usually abrupt withdrawal, so suddenly stopping glucocorticoid use can lead to hypocortisolism. Oftentimes with Addison's disease, the secretion of aldosterone is affected as well. And when this happens, it can lead to hypotension, which is a very concerning feature of those with Addison's disease, but it is relatively rare. Hyperfunction of the adrenal medulla is caused by pheochromocytoma, for example. So this is a type of adrenal medulla disorder. And it can cause uncontrolled production of norepinephrine. If the tumor is large enough, it can cause uncontrolled production of epinephrine as well. This slide shows you the symptoms of both Addison's disease and Cushing's syndrome. Cushing's is actually easier to diagnose, and you could probably tell or assume this just by looking at the image alone, where you see moon face, buffalo hump, truncal obesity. These are common features of Cushing's syndrome, and we had spoken about the deposition of fat in particular areas, so the neck, the face, and the abdominal region. With Cushing disease, emotional instability is common. With Addison's disease, personality changes can be seen, along with nausea, vomiting, anorexia, and diarrhea. And you could see diabetes mellitus written at the bottom of the image, and this is because, as we know, those with Cushing's have an increased chance of developing diabetes mellitus. That's all for today's lecture. Thank you for listening.